Good morning, everyone. Respected teachers and my dear colleagues, a warm welcome to Hyderabad and GI Focus Chapter 1, organized by Dr. Vijay Bada sir in association with TASG. I would like to thank Bada sir and his team for giving me this opportunity. I'm going to talk about early gastric cancer, definition and the diagnosis. So it's first defined by Murakami in early 90s as invasive carcinoma involving only the mucosa and submucosa, independently of the lymph node status. The same definition holds good as of now, and the same definition is redefined and reconfirmed by Japanese society as invasive gastric cancer that invades no more deeper than the submucosa, irrespective of the lymph nodes. As we all know, the main risk factors are H. pylori, tobacco, obesity, alcohol, and processed meat. Out of these, I would like to consider two things. One is H. pylori. It's a class 1 carcinogen. It's a main environmental risk factors. Up to 90% of the gastric cancers are attributed to chronic HP infection. Apart from mild lymphoma, as all we know, it can lead to adenocarcinoma also because of the involvement of the both lymphatic as well as the venous system. There is one interesting meta-analysis of processed red meat. If an average person, if he is taking 100 grams of day, the chance of gastric cancer is almost 26%. Whereas if he takes additional processed meat of almost 50 grams, the risk increased to 72%. And cooking at high temperature also has high risk of getting early gastric cancer. Whereas on the other hand, white meat is negatively associated, and sometimes it prevents also because it's a rich source of polyunsaturated fatty acids. Its main role is in the prevention by blocking the COX-2. Coming to the diagnosis part, the accurate diagnosis is very important in early gastric cancer because it plays very fundamental role in planning the effective management, especially minimal invasive treatments. So the screening tests, which are widely practiced in Asian countries like Japan, Korea, so there the 50% of the gastric cancers are early gastric cancers because they use magnifying upper GI endoscopy and chroma endoscopy as widely. Whereas in European countries, most of the tumors are advanced. The basic difference is because of the wide use of magnifying endoscopies. There are two important premalignant conditions. One is atrophic gastritis, the other is intestinal metaplasia. This is very important because most of the atrophic gastritis patients are asymptomatic, and which is a pre-neoplastic condition. So it has to be identified before it leading to the early gastric cancer. So there are typical endoscopic markers which can be diagnosed in atrophic gastritis. One is the appearance of the mucosa, which is pale, and there is increased visibility of the vascular architecture, which is more evident in the antrum, and the gastric folds will be lost, which is more evident in the body. To identify these in the histology, so there is one protocol called Olga protocol. It suggests minimum we have to take 3 biopsies from the antrum or angulus and 2 biopsies from the carpus, and additional biopsies if there is any other abnormalities are noted during the endoscopy. And the surveillance endoscopy is advised for every 3 years. Whereas intestinal metaplasia, it is defined as an appearance of the intestinal epithelium in the stomach. It can be classified as complete or incomplete. But the problem here is the sensitivity of endoscopy in diagnosing intestinal metaplasia is only less than 50%. Coming to the classification, there are 3 classifications: Vienna, Paris, and Kodamas. Kodamas classification basically the depth and the size of the tumor. So that is mainly in the treatment. I'm not going to discuss here. Mainly Vienna histopathological and Paris endoscopic classifications. This is Vienna classification is being classified into 5. One is the category 1 is the negative, 2 is indefinite, 3 and 4 are non-invasive, that is low grade and high grade dysplasias. 5th is the invasive neoplasm. It's been subdivided into 5.1 and 5.2 based on the depth of the involvement, is a mucosal or submucosal cancer. But the problem with Vienna classification is more than 40% of the lesions are misdiagnosed. Like if they're classified preoperatively as 3 or 4.1, which is high grade dysplasia or low grade dysplasia, on post endoscopy resection they're diagnosed as cancer. Coming to the macroscopic classification like Paris, as we all know, it's type 1 and 3 are protruded excavated. Type 2 is into 3 types like superficial elevated, flat, and depressed. These are the endoscopic pictures of different types of Paris classification. Endoscopy plays a very important role in making diagnosis, but the problem here is, unlike advanced gastric cancer where the findings are very evident, here the changes are very subtle. So those countries like Japan and Korea, where they have the habit of doing endoscopic screening regularly, so the chance of identifying there is more because they do it every 2 years, even in the asymptomatic patients, if the age is more than 50 years. So to avoid missing the presence of cancer, so gastric observation should be well understood and thoroughly detailed examination is needed. So for that, we have to pay attention to points such as standard quality, like proper pre-procedure fasting instructions, defining the minimum duration of the endoscopy, lesions limiting the blind areas, so means we should not miss blind areas, clean up the mucosa adherent to the gastric wall, suction the excessive gastric juice, and supply the sufficient air. So by doing these precautions, we have to identify the subtle changes like slight color changes, loss of visibility, thinning and interruption of the mucosal folds, and there is any spontaneous bleeding. So if we pay attention to these points, the chance of identifying the early gastric cancer, so the sensitivity increases. And if there is any discrepancy, reduction of the air volume within the stomach is effective for observing the wall thickness and the hardness.